Yeah, one more that's joining. All right. Well, it is 7:02. We will get started. Thank you on behalf of Northeast South Dakota AHEC for joining us tonight for our June monthly webinar. My name is Sheila Manier. I work as the Associate Director with AHEC. Michaela Titus is waving at you. She's our Executive Director. We are honored to have John Gruber from Avell. He is the EMS operations manager there at Avell. I've had the privilege to go down and observe there at Avell a couple different times, and it's very interesting. If you've never had the opportunity to use their services, he's going to talk a little bit about just give us a refresher on that and then some other information. So I will let you take it away, John.
Sounds good. Thanks, Sheila. Good evening, everybody. As Sheila said, my name is John Gruber, and I am the EMS Operations Manager with Avell. And if you aren't familiar with our service, we provide telemedicine in ambulances across South Dakota and other states now as well, but we got our start in South Dakota. So tonight's presentation, I'm used to presenting on Teams, not on Zoom, so please bear with me. There's a video I want to show, a couple of videos actually. I may need confirmation from those of you who are attending that the audio is working, audio and video are working correctly when I get to those. And then I have a special guest joining. She is going to jump on probably in about 20 minutes, no, 15 now, to share about her experience because she has a unique experience with Avell and with telemedicine. So I'm going to share and then.
When you share, there should be a little button in the bottom corner that says share audio, and that should help when you get to your videos.
Okay. Oh, share sound. There we go. Perfect. Thank you. And we're going to go here. All right. Can everybody
Yes. Yep.
see the PowerPoint? Okay. It says telemedicine in motion.
Yep.
All right. I talked with Tony Olson, who, if you've utilized our service at all, you've probably seen him. So I'm going to start out with just some general education, talking about capnography, and then I'm going to switch over to telemedicine in motion after I give just a very brief overview of capnography and why it's, as it says here, a critical tool for pre-hospital care. I talked with Tony Olson. He's one of the paramedics here on staff, and I said, hey, you've had a lot of interaction. He, takes the majority of the EMS calls that we have here. I said, hey, as you've been working with our partners, what are some things that you have seen that we could help collaborate with and improve on for patient care? Ultimately, our goal, anything that we do with Avell is working towards better patient care and better patient outcomes. And so he mentioned a few things. And one of those that he mentioned that he really started utilizing when he was working on the ambulance is end-tidal CO2. And we really try to talk about, when we talk to EMS personnel, about all levels that can use, so from BLS all the way up to ALS. And so this is definitely something that I think is important and something I just wanted to talk about tonight. So we're going to just give kind of a brief view of what capnography is. I found a video. Stryker gives a very practical video on what you should do to hook up end-tidal to the LifePak 15, which everybody has. And so I'll be showing that video. And then we're going to run through a patient scenario. So I don't know if these education sessions are interactive. I much prefer teaching in person because then we can kind of dialogue and things like that. So I don't know if Sheila allows you to participate in these. But as we do this patient scenario, I'd love to I have parts of the slide just come up as we talk about it. So I'd love to have you interact if you would be willing to unmute yourselves when you get to that patient scenario. And then after that, when our special guest jumps on, then we'll move in and talk about telemedicine in motion. And then we have a video that we've used for training sessions now since we've gone live in South Dakota. So I'm just going to review that video and talk about some of our services. And then for the data nerds, I have some data from telemedicine in motion, and then we'll have some time at the end for questions. So thanks again for joining me. Just in case you don't know me, I've been a paramedic for 12 years now. I worked on the ambulance in Sioux Falls, then flew for Care Flight out of Sioux Falls. And then for the past 2.5 years now, I've been the operations manager with Avell. So tonight's topic, capnography and EMS. So it's a critical tool for pre-hospital care. And what the definition of capnography is CO2, so carbon dioxide measurement in exhaled breath. And the purpose of monitoring end tidal is to get that real-time view of ventilation / perfusion monitoring. So with the SpO2 in patients that are breathing, with the SpO2, we measure the oxygenation. And then with the end tidal, we measure the ventilation. And so those are two very important things. And so I was doing research for this, some of them said even, including this as a primary vital sign when you are using this in pre-hospital care. And again, that is something, it's non-invasive. So everybody from EMTs all the way up to paramedics can use capnography as a tool. So the types of capnography, as we talk about this, so there's mainstream, which is a sensor right at the airway, and then side stream, which is CO2 drawn via tubing. And all the tools that I'll be talking about tonight for use in EMS use that mainstream sensing. And so the two main ways that you do that, there's a special nasal cannula that you have that has the sensor right under the nose. And then if you are intubating a patient or if you're using an extraglottic airway device, then that little cap goes on right at the end of the tube or at the end of that iGel or ping tube or whatever you're using there. And then that monitors the CO2. Really in pre-hospital care, we're not going to see that side stream one where there's a tube and then there's a secondary tube that sucks some of the exhalation there and then measures it in a different device that's separate from the monitor. But with the life packs, that's all built in. So you're able to do that in the mainstream monitor. So what is capnography? Capnography, as you'll see, contains two different items. So that's the waveform, and showing up on the next slide, we'll show you what that waveform looks like. So the waveform and then the numeric value. And so everybody has that end tidal reading, which is that numeric value. And so then with those two things, we can monitor a patient's ET CO2. And the waveform is what's really going to be used in a pre-hospital care to help with your patient and to figure out what might be going on with them or with some of the interventions that you're giving, what's happening with that patient's respiratory effort through that waveform. So first question, and I don't know, I think I can see the chat too, but first question before I go on to the next slide, what is a normal range for an end tidal? If anyone wants to.
35 to 45.
Thank you. Appreciate that. Yes, a normal end tidal is 35 to 45. And I had one instructor that said, unless you give me the units, it could be 35 to 45, anything. But yeah, 35 to 45, and that's millimeters of mercury, which is what pressure is evaluated in. So understanding the capnogram, and this is one of those things that as you look at this, first you have to kind of wrap your mind around it, because when you think of respiratory effort in breathing, you think of inhaling, you think of the things going up, and so you have to flip your mind over when we talk about the capnogram here. So if you can see my mouse, there's 4 different phases to the capnogram, and there we have that normal range is 35 to 45. And so phase 1 is baseline, or when that's dead space. So that's when you've the baseline for the end tidal. And then when you exhale is where this starts to go up. And you can see when you breathe out, you have that quick ramp. And so that's as you're exhaling the oxygen, then it turns into phase 3, which they label as the alveolar plateau. And then that's where they take the reading of that end tidal is right at the end of exhalation before you inhale. So the inhale is when your lungs are full of air. And then when you breathe out, then it moves up till you're fully at the end of your breath, and then you breathe in. And you can see why. So this is the normal one, like I said. This is some more advanced. They have these alpha and beta angles. Those are for more advanced end tidal reading, but just for the base one, the things that we're going to be concerned about are what this shape is, and then knowing what the scale is. So the scale is going to be over here. So 0 to over 100, depending on what it is. That normal range is 35 to 45. And then this is the time. And then whenever you use that end tidal CO2 monitor on your monitor, it'll also give a more accurate respiratory rate, because it just counts how many of these waveforms there are in a minute, and then keeps that as a good calculation, so you can see how quickly or slowly what the patient's respiratory rate is. So you just have to remember that the exhale, and for some reason my brain doesn't want to do that, but when you exhale, that graph, that capnogram, that waveform goes up to the exhalation. And so you can see you exhale pretty quickly, and then as you get towards the end of your exhalation, it kind of slows down, which is why it tapers off. And that's the highest level of where they take where that numeric value comes from. So I'm going to jump over, and then I may have to stop the sharing. Did that go over to the web, or is it still on the PowerPoint?
It is still on the PowerPoint.
Okay, stand by. I'm going to go stop share. All right, then I'm going to do this, share sound. And right here.
It is on the web page.
End tidal CO2 monitoring, or capnography.
Is everything working properly?
Yes. Yep.
Okay, perfect. So this is your LifePak monitor. You recognize that there. And then she's just going to show you how to hook it up properly and how to set up your monitor to read that capnography, the waveform.
Is another helpful tool in the LifePak 15 monitor defibrillator. Use it to continuously measure the expired carbon dioxide in adult and pediatric patients. It's important to be familiar with your filter line's instructions for use. Okay, let's set up for monitoring. You'll be working with these MicroStream accessories, either the airway adapter and filter line for intubated patients, or a nasal filter line for patients who are not intubated. The 15 is on, open the connector door and connect the filter line. Turn the filter line clockwise until it is tight. There's a CO2 initializing message, and you see dash marks here for the respiratory rate. You can display the CO2 waveform in channel 2 or 3. Use the speed dial and select CO2 from the menu. The waveform will be a dashed line until the monitor finishes initializing. Then it becomes a flat line. Now, put the filter line on the patient, and there is your CO2 value and waveform. The monitor automatically selects the scale for the best visualization of the waveform. For your reference, CO2 must be greater than 3.5 for the waveform to appear, and at least 8 to recognize a breath and count a respiratory rate. The respiratory rate is averaged over the last 8 breaths. The end tidal CO2 monitor has a built-in apnea alarm. Once a valid breath has been detected, the apnea alarm triggers if the monitor hasn't detected a breath for 30 seconds. The message, "Alarm Apnea," appears, and the time since the last detected breath. You can temporarily silence the alarm tone by pressing Alarms. First, check the patient and whether the filter line is still attached. The alarm clears when the next breath is detected. When you're done with CO2 monitoring, disconnect the filter line and dispose of it. Do not reuse, sterilize, or clean CO2 accessories. They are for single-patient, one-time use. There are messages built into the CO2 monitor to help troubleshoot problems. Refer to the troubleshooting tips and the operating instructions for the messages and corrective actions. Remember, CO2 monitoring is a tool to be used in addition to patient assessment.
All right. So there was the example of how to hook up the end tidal CO2 and monitoring to the patient. And I'm going to go back to my PowerPoint. Okay, there we go. So I should be back on my PowerPoint now. A couple of things I wanted to just highlight there. You know, most of you will have the SPO2 in that channel 2. And so just to slide down, you can put the end tidal monitoring on channel 3 because there's 3 channels there on the front of the monitor. So have the telemetry on top or the heart rate, then have the SPO2 or the oxygen saturation on that second channel, and then scroll down and have the end tidal there on the third channel. The thing to remember is you need to plug it in and twist and then let it initialize so that it senses, because it uses pressure, so it needs to sense the pressure that is present in the air first, and then put it on the patient after. And that's the same thing, if a patient is intubated for the advanced level providers, to make sure you initialize it before you put it on the patient. And then you can use it with eye gels as well. So I know a lot of instances where services, in cardiac arrest are using just eye gels rather than intubating. And so you can put those devices on eye gels as well. But they recommended in the one study that I read is plugging it in, initializing it, and putting it on the eye gel first before you put it in the patient, because that can kind of throw off the pressure sensing that's happening there with the sensor. So we're going to do a little bit of patient scenario. If we get this to here, perfect. So you respond to a 60-year-old male with known COPD, chronic obstructive pulmonary disease. When the weather, I'm sure many of you around the state have experienced that hot, humid weather recently, and that is a prime time for those COPD patients to have that exacerbation because of that weather. And you arrive on scene and he's complaining of shortness of breath. He's wheezing, and you can see, because he probably either doesn't have a shirt on or just has like a sleeveless shirt on. You can see that he has that accessory muscle use that is going to be happening there. So you hook him up to your life pack and you do a good patient assessment. And so he is breathing 28 times a minute. His SpO2 is 88% on room air. His heart rate is 110, and his BP is 140 over 90. For those of you following along at home, those vital signs are not within normal limits. So what are some things you're thinking as you are assessing this patient? He's probably sweaty too because it's hot. Maybe he was sitting on his deck. And so what are some things that you are going to do initially, whether you're BLS or ALS? There's something everybody can do to assist this patient. So either put it in the chat or take yourself off mute and let me know what you think.
I'm going to ask him if he's regularly on oxygen or not.
Okay. Sheila's going to ask if he's on oxygen. And he's probably going to say something like, oh, I left my tank at home because I'm on vacation, or I ran out yesterday or something like that. But yes, he's usually on oxygen. Corolla asked in the chat, what are his breath sounds? So yeah, you hear wheezes throughout, diminished in the lower, and then yes, we are going to find out what his end title is. Normal sats. Yep, that's a good question too, Corolla, because sometimes those COPD patients, his normal sat might be 88, but he says usually, if he remembers right, it's in the low 90s. So it is a little bit lower than his normal. So we put on oxygen via nasal cannula. And then he has an inhaler. So if you're an EMT, you can help him with that inhaler if he's kind of too weak, or he's like, oh man, I've tried it so many times. Some services have the ability, if he has an at-home nebulizer, you can help him with that. Definitely the ALS providers, if there are any on the call, you're going to be working on those bronchodilators to assist the patient. And then, as we're talking about tonight, we're going to put that end tidal nasal cannula instead of the oxygen nasal cannula. So they are two different cannulas. The one, just hooks up right to the oxygen port, and then the other one has another port on it with that orange at the end. So this is what you see on the waveform. As we said earlier, normal is 35 to 45. So his end tidal is higher than normal, which means he is retaining carbon dioxide. And we can see this shape of this. If you remember, the normal one kind of went up here and then came across and then down. But this one is curved off. Anybody in the chat, does that look like something? Does that remind you of something as you look at that shape of that waveform? A shark fin. Yes, Sheila, that is a shark fin. So this is a classic capnogram waveform in the presence of bronchospasm. So two patient scenarios that we have the COPD patient and then also the asthma patient. And why that is, has he been intubated before? Yes, 5 times, he says. This is the classic shape in someone that is having that bronchospasm. So as we said, yep, he has the shark fin waveform, and then his end tidal is 50, so he's retaining CO2. So he has a prolonged exhalation because, in normal exhalation, as we talked about, you kind of breathe out really quickly, and then it kind of plateaus off and then falls back down. But with somebody that has this bronchospasm, they have a harder time exhaling, and so it takes them longer to get that out rather than quickly like that. So if you see something like this when you're doing that end tidal, you know that that patient is experiencing the bronchospasms. So if that patient, does happen to go into respiratory arrest, we need to avoid that aggressive ventilation, because if you breathe fast for them, once they, if they go into respiratory arrest, they aren't able to get that oxygen out. So they're going to retain even more CO2. So you're going to create more problems by not allowing them to exhale the full way. So you're a great provider, however, though, and you get him some bronchodilators and help him calm down, get him into the cool back of the ambulance, get some oxygen, and he starts to breathe at a more normal respiratory rate, and his end tidal lowers down to 42, and off you go. So again, this is one of the waveforms where if you have a patient that's in respiratory distress and you put the end tidal nasal cannula on them, this is a classic finding in that asthma or that COPD patient. So other clinical applications that can happen and can use with capnography. So to verify that your endotracheal tube is placed correctly. So the only part of the body that has ventilation is in the lungs. So if you're not in the lungs, you're not going to get a high a normal CO2 rating or a CO2 rating that is something that that waveform can measure. The CPR quality monitoring. And so if you are doing good quality CPR and you have an end tidal hooked up, it's going to reflect that perfusion that you're doing with CPR. So again, that situation where you might have an iGel or an EGD to put that end tidal CO2 monitor on that device during CPR. And then it does detect ROSC, because when a patient gets return of spontaneous circulation, there's a significant rise in end tidal because they've retained all that CO2 during the cardiac arrest, and then they start breathing that off, so that that bumps up when they start when they have that change in circulation. And then, you know, two of the things I think, especially for, you know, EMTs as well, to monitor the ventilation, whether you're bag valve mask or whether it's a patient with an altered mental status or overdose, those kind of things that can really help you have that other picture so that you don't have to, you know, hone in so specifically on their respiratory rate or on their effort of breathing. If you have that picture on the monitor, obviously pay attention to the patient, but that can help that extra, you know, that extra ability for you to monitor what's going on with your patient. So we talked about some of these already, that shark fin waveform, the overdose or the seizure, you know, when they kind of are nearing that respiratory arrest, so you can be ready with what to do. And then, you know, trauma patients, that's one we don't maybe think of to put the end tidal on, but those trauma patients that are having trouble with other parts of perfusion, you know, due to blood loss or things like that, can be assisted with having that end tidal on them. So summary or take-home points for capnography: it's fast, reliable, and you know, some of the studies I read said, you know, it's even, I looked at the South Dakota BLS protocols, and it is in the protocols that we should be putting end tidal on our respiratory patients. So it's fast, reliable, and essential. It's to improve your patient safety and clinical decisions, because you can help that inform your clinical decisions. And then make sure you know how to get that waveform. So once you have them hooked up, scroll down to channel 3 and make sure you get that waveform on the monitor so that you can make sure you're monitoring that patient effectively. So there's the resources. I think this is being recorded, and I can obviously get you the slides if you want them. Those are the resources that I used to come up with tonight's topic. Any questions on end tidal monitoring before we talk about telemedicine in motion? Okay. I am just going to, I don't see if she's on here yet. I'm just going to text the special guest.
I'm assuming you're texting me and I'm here.
Oh, there we go. Oh, that's funny. Because I've had this happen on Zoom before as well. Since I forward you the link, you appear as me on the screen.
Yeah. Man, that's
okay.
That's okay.
Yeah. So we have not John Gruber, not my twin, not somebody else named John Gruber.
We kind of look like a doppelganger, though. I can see why people will probably be confused.
So no, our special guest tonight is Lauren Olson, and some of you may have crossed paths with her at some time here, but I asked Lauren, we're going to talk about Avell eCare EMS, and so I asked Lauren to come on and share because she is in a unique position. Lauren started working for Avell, I think in March. So she's been working with us now for a few months, but she also works in EMS around the state of South Dakota. Specifically, the service that has Avell is down in Beersford. And so she's in a unique position because she works with me on this side of the camera of telemedicine, but then has also had the experience of being in the ambulance and working with telemedicine. So she is going to share just a little bit about her EMS career. And then I've asked her just to prepare a couple questions about, you know, why she utilizes the service, any tips that she has out there for you. So this will be a great reminder if you have the service in your ambulance, and if you don't, talk to your director and see if we could still have you become part of the program, because we would love to be able to, as the things I'm going to share later, we'd love to be able to support you in that way. So thank you, Lauren, for jumping on. And oh, there, look, she changed her name. Look at that. She's even technologically advanced.
It did it, but it did it on its own.
Seriously?
No,
Yeah.
I did it.
Oh,
there you
Michaela
go.
did it. It's like AI is getting creepier every day. Thanks, Michaela. All right, take it away, Lauren.
Perfect. Well, my name is Lauren Olson. Here's my introduction. I told Gruber I hate speaking, period, except for when my loud mouth goes to be a patient advocate. Apparently, it just kind of flows out then. But I am a mom of two. I now have a 10-year-old girl. Her name is Peyton. And then what my phone says is a 23-month-old boy. I can never figure out the months. He's almost 2. And his name is Brecken. I have a significant other, a fiance. He's actually a PA in the emergency department in Pipestone, Minnesota, and in Brookings, South Dakota. What I do in my spare time, maybe not spare time, I farm full time, and then I trickle in some EMS stuff. So right now, I'm a paramedic in Brookings. I work 1 24-hour shift a week, and then I trickle in and do PRN jobs at Avera McKinnon at the freestanding ERs, and then also at Avel. So yes, you can have that. Sorry, momming at its finest right now. So my background in paramedicine, I had to write it down because apparently I like to move around a lot. I started off as an EMT and then moved into a paramedic role in Brookings. So that was from 2011 until 2017. And then I actually went on where I met John, and that was being a flight paramedic at Avera. And so I did that from 2015 to 2020. While I was there, I became a certified flight paramedic, or what we like to now kind of push into the critical care role, which I absolutely thrive and love. And then I also was a base supervisor in Sioux Falls, so I might have talked to a few services out there. And that was from 2018 to 2020. And then an opportunity came to me in 2021 to go back to Brookings, and I needed to work full time again because my significant other went to PA school, so I took that job. And then I went to work at the freestanding ERs as an Avel. And then I moved to Beersford to farm full time and decided to jump on the Beersford ambulance because I've got a ton of spare time. And I do some volunteering there, and that's kind of where I started using Avel. And honestly, I'm just going to be kind of transparent. I never used it. I never really wanted to use it before I started actually working at Avel. The reason why I didn't want to, I think there was this big thing that was, you know how EMS people talk, that maybe you were going to be dictated on the side of whoever's on the camera is going to tell you what to do. There's a doctor that's going to come on and tell you how to treat your patient. There's this nurse that's going to come on that's going to tell you how to treat your patient. And honestly, it is absolutely not that. And I didn't know that until I started working there. So I have used it actually for some pretty critical calls in Beersford, because I run as a BLS unit. I can start an IV in Beersford. I can run some fluids. They have like D10 that I can run. But otherwise, like, I can't really do a whole lot out of in my comfort level, maybe is a better term. But I do have an EMT that sits in the back with me, 1 or 2, depending on who can respond, if anybody can respond. And then it's just kind of nice to have the camera up because I can say what I'm doing and they write it down word for word. And then afterwards, because I do like charting for myself, then I can go back, I get it faxed to me, whatever hospital I go to. And when they fax it to me, then it's easier for me to go back and write exactly what I do, just because it's so different from Brookings. When I'm in Brookings, I just remember and can do it. You know, there's times where I think, oh, it would be nice, especially in a code situation where I'm sitting there and somebody can say, hey, it's been 2 minutes, do a pulse check. Hey, it's been 3 minutes, give another epi, something like that, where usually when we're charting afterwards, it's like, oh, maybe I should have given it sooner. Maybe I shouldn't have. So that's why I started using it, is when I actually started charting for other services, and I could actually sit there and say, hey, this is actually how you transmit, because, or like a 12 lead, because you don't really use it on a day-to-day basis, especially in smaller communities. And so kind of having that refresher, that somebody that's up in the sky saying, hey, no, this is actually how you do it. And just knowing that when we're saying or suggesting things, we're not suggesting it out of spite, but it's more so saying, hey, maybe you should try this because you might not be thinking of it, especially in a critical situation. There's things that totally slip my mind where I wish my partner, EMT, another paramedic comes on that says, hey, what about this? Have you thought of this? Because half the time I haven't. And so that's why I use the service when I'm actually working in Beersford. We don't have it in Brookings. You know, I would probably utilize it when we're in Brookings. The transport time is a lot shorter. So I kind of understand that sometimes it's not easy to use in that way. But yeah, that's why I use it at this point. I don't know if there's anything else you wanted me to touch on that, John. Otherwise, some tips that I have. The biggest thing I would say, and that I started doing actually in Beersford, is please, please, please call in and actually do a camera check with us. There's a lot of times that, especially before I started using it in Beersford, it hadn't been used for a while. We haven't been doing camera checks. And so it was malfunctioning. And so it's just kind of nice to call us, especially like when we're there. We would love to do camera checks with you guys. Sit there, we could BS, not whatever. Like, and then it's kind of nice also because a lot of times those iPads, when they're up in the corner there, it looks like, oh, hey, this is where the iPad should be at. And actually, where it's placed at, it should almost look like it's looking towards the ground, because we want to look at the patient more than we want to look at the back corner of the ambulance. And that's where it kind of looks, where the camera is placed on the iPad, it kind of looks that you shouldn't have it as far down as you do. So we can kind of just tell you guys, hey, during a camera check, can you just push your iPad down a little bit so we can have a better view of the patient, so that we can kind of see things on that aspect. You know, a lot of times, another thing for tips for utilization, call out your vitals, call out what you want us to write down, because a lot of times we can't see your monitor because we can't zoom in like we could in an actual ER room. And so you just saying, hey, I just got a blood sugar, it's 60. Hey, this is a whole set of vitals, and we'll do it, timestamp it for when you tell us. And so it's just kind of nice, just call out what's going on while you're doing it. It may sound like, oh, this is so stupid, but it's really not for us. Plus, you're going through your ABCs, your 1, 2, 3s, and that you're actually doing yourself a favor at the same time, because you're doing it out loud. There's a lot of times where it's like, oh, hey, I saw this and I did this. And so it's just kind of nice. Say everything out loud so we can write it down. And then when you're charting, if you don't want to use it, don't. If you do, great. But otherwise, yeah, whatever you want us to write down, we definitely do that. So those are kind of my tips for utilization. If anyone has any questions, feel like I've been in this a long time. I'm sure a lot of you have heard my name, at least with the different roles that I've been in. I think a lot of you know that I also lost my husband in 2018. And so, you know, there was a lot of stuff on the news about that. And so I kind of have a little bit of background on, you know, different aspects on that too. So if anyone ever has any questions about EMS in general, going on to be a paramedic, flight paramedic, anything like that, please reach out. I love talking to people not in situations like this. I'm just rambling at this point, but yeah, just I have a very big passion for patient advocacy and just kind of getting out there and telling people why you do this job, because it ain't for the money, it's for the love of the job.
Awesome. Thanks, Lauren. I appreciate it.
Yeah.
Yes. Appreciate Lauren's time and She has been fantastic joining our team here at Avell, and yeah, we appreciate all her experience and what she brings. And it's true what she says. She loves to talk about EMS, and would love to talk to you about that. I will give a sneak peek. Breaking news: we are going to have an Avell open house during the South Dakota EMS Association conference this year. The conference is in Sioux Falls, so the night before the EMS conference, we're going to have an open house, and so we're going to invite everybody that is one of our telemedicine and motion partners, and hopefully Harvest is not going too crazy that night, so Lauren can join us, or we'll have somebody else run the tractor so she can come up for a little bit and say hi to everybody. So, but yeah, definitely call in and do those camera checks. I appreciate Lauren saying that, and yeah, thanks, Lauren. Okay, moving right along. Sheila, do we have an hour, or the meeting was set for a little bit longer than an hour? So
You can go as long as you like.
okay.
Well,
I just want to, yeah, I'm gonna to kind of share. So I'm sharing my PowerPoint again. Oh, I'm gonna double check it. I think the audio is clicked, so I think we should be good. So yeah, we shot a little scenario. And thank you to Dell's Ambulance. They often get roped into helping us out with things because they are the closest service to Sioux Falls that has Avell. So they are the star of this scenario. So we appreciate them having us do that. But this is a scenario to what you experience. And so hopefully just reinforces a couple of those things that Lauren said, and then I'll make quick mention. And so we've broken it into chunks so that I can talk a little bit after each chunk, but then we will go from there. Audio's coming through okay?
Avell EMS, this is Tony. How can I help you?
Hi, Tony. My name's Alan. I'm an EMT with the Del Rapids Ambulance. We are en route to a chest pain call. Can you bring us up on camera?
I would be happy to. In just a moment here. Can you see me and hear me all right?
Yes.
All right. And are you guys ALS or BLS today?
BLS.
All right. And what do we have going on?
We have 46-year-old male patient. Chest pains started about 10 minutes ago after mowing for about 45 minutes. His heart rate is 104. SpO2 is 89% on room air. Blood pressure is 190 over 113.
And have you got a EKG yet?
Yeah.
Okay, so that first little bit of the encounter is when we pull you up on camera, we may ask you if you're ALS or BLS. We're working on having some way that can automatically come up so that when our staff pulls us up there, pulls you up on the camera, we'll know right away. And when we pull up our software, so that we won't have to ask if you're ALS or BLS, we can eliminate that question. But basically, like the three things we want to know is the chief complaint. You're going to call in with the 1-800 number and tell us your name and what service you're from so that we can pull you up. And then basically like a chief complaint. And then we probably ask ALS and BLS, and then how we can assist you in the call. And so you can see that individual is ready there with what's happening.
Yes, we do.
All right. So we'll go ahead and have you transmit that over to us as well. And we'll have our physician take a look at it.
Sounds good.
All right, let's go ahead and get some aspirin on board. So if you can give him 324 of chewable aspirin. We'll put some oxygen on as well, 2 liters via nasal cannula.
George, can you shoot those up for me?
Okay, so that's one. Again, the LifePak integration and the ability to transmit 12 leads. We have the ability to receive 12 leads directly from your LifePaks to Avell. and then our board certified emergency physicians will get on camera and be able to interpret those. So that is something, another thing that Tony and I have talked about is ensuring that you get that time, depending on that time frame when you get the EKG. So, a lot of individuals maybe are used to just getting the 12 lead while they're running it down the road. We may ask you to either like, hey, if you're going into the house, get a 12 lead right away, or like maybe that's one of the first things before you start going, just so we can get a real clear picture of what is going on with that 12 lead. And then, Tony on this call, he's a little more directive, obviously, but we have had instances where maybe it was the first time an EMT went out and was doing a 12 lead and they just needed those reminders. Definitely there were times when I was on the ambulance, middle of the night, and you have an altered mental status. And like Lauren said, someone to remind you like, hey, what's the blood sugar? Or like, tell me what that blood sugar is. And I go, oh, shoot, I forgot to grab one. So I can do that right away. So this call with this individual, Tony's being a little more directive, but we will come on and assist you with however we can help you.
Hi guys, Dr. Coltman here. Just grabbed the EKG. What can you tell me about your symptoms, sir?
So this shows, whatever you need. We'll start with either the paramedic or one of our nurses helping out. We share staff with the emergency department. And then if you need a physician to come over assist, we can do that. But again, we're not going to automatically include a physician on the call or, do that. That's going to be up to you. We may offer it if we think there's helping. And then anytime that you transmit us an EKG, that guarantees that one of our physicians will take a peek at that and come and let you know what's happening.
And then how far away are you from a facility with interventional cardiology capabilities?
We are approximately 10 minutes out.
Okay. All right. So once we get those patches on, I recommend that you transport the patient emergently to the nearest facility.
And then I'd be more than happy to call report over to the hospital for you and let them know what's going on and what to look for.
Perfect. Thank you. And
they are about 8 minutes out. Any questions? Awesome. I'll let you know you're expecting them. Okay, so I was able to give report to Rebecca over at the hospital, so she'll be expecting you guys.
Thanks for your help. Do you mind staying on until we get to the hospital?
Oh, absolutely. And do you have any other questions for me at all?
I do not.
All right, well, great job today. They are.
All right, so that last part of that encounter showed the example of our staff calling in report. So really what I like to tell people is anything that we can do so that you can maintain patient care, we want to be able to do for you. So calling report is one of that big one. In close to 40% of our encounters, we call in report so that you can take care of the patient and we can give that receiving facility an accurate picture. Yes, I do see that in the chat. ALS, BLS depends on who is on the ambulance. The state has to have an identifier of whether the ambulance provides ALS or BLS, so we'd probably use that. And then, if you clarified then once we're on that ambulance, what those capabilities are that you have to do, we're happy to do that also. So we'd probably put a little asterisk next to your name there, Chuck, for sure. So reviewing what the clinical support and that coordination support is, kind of a couple of things I want to highlight is the cardiovascular needs. The most serious one obviously is the cardiac arrest. And so we run between 3 and 5 cardiac arrests in our hub between our ER and our EMS service lines. So like Lauren mentioned, that timing of the cardiac arrests, what you need to be doing to, make sure that you're giving that patient that best care. Another big one is trauma care and activating the trauma system. We participate in the regional trauma calls with the state and talk a lot about that early activation of the trauma system. And so if you know a patient is experiencing severe trauma, we can get that activated at your facility and then get whatever needs to happen for that trauma system. Something that has come up, and we're currently within our scope, that medication decisions or anything that you're doing in the ambulance, we work within your scope. So if you are a BLS provider, we're going to help you practice to the best of your ability level as a BLS provider. And if you're an ALS provider, help you to the best of your ability as an ALS provider. So like Lauren said, Beersford ambulances probably have IV supplies. We're never going to ask an EMT to start an IV and put fluids in because that's currently outside their scope. So talked a little bit about EKGs already. The documentation, again, Lauren mentioned that's a huge thing that we can help that documentation. We are investigating what it might look like to have some alternative documentation available through Image Trend. So stay tuned for that. I think this right side highlights some of those extra things that we can do. So whether that's that air medical activation, poison control is a big one. Again, like I always talk about, they're the experts when it comes to overdoses and medications and things that they can do to help stabilize or treat patients that might be experiencing something interesting that they've overdosed on. We talked about support. Another one that we offer is interpreter services. So we work with a third-party company that has over 250 languages available for interpretation. And then that real-time education mentoring. Lauren is a prime example of, she's been in EMS for close to 15 years now. I think if I remember when she got her EMT, what she said. And so, even coming up on 20 if she got in 2007. So she has a lot of experience in EMS, and our other staff, do as well. And so being able to bounce those ideas or, those patient care scenarios or talk with them about what's happening, we feel is a great resource to you in the back of the ambulance. Question in the chat: have there been dead zones when transmitting EKGs? Yes, the EKGs, because those rely on the 4G network that, and I can't speak to specifically to the 12 leads to the EKGs. Not sure which network, but then the Avel system. Yes, there are a few areas around the state that are geographically isolated, but I think we've been pleasantly surprised at what our uptime is. Our staff and the EMS personnel, they say they have technical issues in about 30% of the encounters that we have, which maybe seems like a high number, but the majority of those are resolved before patient contact or don't impact patient care. So they say there was technical issues and then they rate the impact on the care of the patient. But we have somewhere close to 96% of successful encounters so there's very few that actually fail because we aren't able to assist through the audio video. But yes, our system uses both the Verizon and AT&T network, and so there are still areas where we aren't able to connect, but I think everybody that has used the system and everybody on our side as well has been pleasantly surprised in some of the areas where maybe you're on AT&T and you don't get service, but we can get it on Verizon. But yeah, for sure, unfortunately there are still some areas. We have investigated potential for satellite, so we're hoping with as that becomes more cost effective, that maybe we can start trialing some of that as well, especially in those rural areas. Thank you for that question. So here's our current footprint. We have 105 agencies on board with us, and I think we just installed in another ambulance in so we actually might be up to 110 ambulances. And then so 84% of South Dakota agencies have telemedicine in motion. Some more data. Here's our chief complaints for South Dakota. So the life of the program, trauma, neuro, so that would include altered mental status, stroke, things like that, and then cardiac chest pain. Those are our top 3 chief complaints, and those have stayed pretty consistent throughout the life of the program. We have over 1,700 encounters in South Dakota, and then the majority of that is those 911 transports, so 86% is 911's. We currently assist with 911 transport and interfacility transfers. And then the median patient age, and then the emergency severity index, that's something from the hospital world that patients are rated depending on the severity of their needs or how they present. And so 1 is the most severe, and then 5 is the least severe. And so the median for our patients is 2. So calling on the acute patients, which is appropriate, use of the service. However, you can call us for anything that you want. So if you haven't heard, the state of South Dakota is doing a special look at EMS in the state. They've put together an interim committee. There's different committees that when South Dakota legislature is not in session that they make. And so one of the committees, due to the bill that went forward to make EMS an essential service, that failed this year. And so one of the committees that came out of the legislative session is looking specifically at EMS and focused on funding, partly because of this bill, and then also staffing. With definitely their, you who are on this call have probably experienced staffing issues in your service. And so they're specifically looking at those things. So we sent out another survey. We did it early on after Telemedicine in Motion started, and we just sent it out again recently. So first of all, thank you to those who filled out the survey. We really appreciate it. And we're presenting on Monday in Pierre to that special committee about Telemedicine in Motion and how it's helping support EMS. And so we had 43 individuals respond to the survey that we sent out to all the agency directors and or points of contact, and 43 responded representing 39 agencies. And so 72% said they feel that telemedicine helps with recruitment and retention. And then you can see these other stats. 4.3 out of 5 allows more time for hands-on patient care. 4.4 out of 5 improves quality care, and 4.5 adds staff's capacity to care for their community. So we were overwhelmed by the responses that we received, and we're excited to see that what we're doing and how we're partnering in your community is having a positive impact. So some of the future things, we're always, we have an innovation team that's always working on things, and this is I think one that might have some value. We often hear directors are talking to us, or we ask people and they're like, oh, I was in the middle of a call, so in order to start the service you have to call a 1-800 number. So I was in the middle of a call and I couldn't get to my phone, or I didn't have a free hand to make a call because I was already taking care of the patient. Or they're cleaning up the truck at the end of the call and they look up in the corner and they're like, shoot, there's that iPad, I should have called Avel. So we are actually I'm meeting with the state PSAP coordinators this coming week, and we're going to start brainstorming about what it might look like to have Avel as part of 911 dispatch. So if, for instance, Dual County gets dispatched on a call and their dispatch coordinator knows that they have Avel, they might say, hey, you're dispatching, this sounds like a serious patient, would you like us to call Avel for you? So rather than you having to pull out your phone and give us a call, the dispatch will call us and tell us what's happening, and we'll be able to pull you up without you having to make a call. So I think that's one way that we're looking at improving that opportunity for you to utilize the service. We have a couple other things brewing as well related. Like one thing I mentioned possibly is documentation, and then some other things that we're working on with the Department of Health that will hopefully be rolling out here in the future, either prior to the EMS conference or right around that time, that we'll be sharing some new ideas on how we can support you in the ambulance. Thank you again so much to Sheila and Michaela and the Northeast AHEC. I've had the opportunity now to participate in a couple of events with them, and definitely appreciate the partnership and their willingness to be proponents of our services, not just in the ambulance, but everywhere. So thank you for letting me attend tonight. And if you have questions, I'm happy to take time to do that. Otherwise, enjoy the rest of your evening and have a great weekend. Yes, Corolla asked a question about children and youth with special healthcare needs. Yes, I have met with Project Austin, and we have record with a couple of those patients that are in the state. We have their, we ask if you have a Project Austin or a patient with special needs in your community, and there are special instructions that are given to you for that patient, and you're going to be picking them up in the ambulance, please let me know that, and we can actually save that documentation in our software. Or like with Project Austin, they have that QR code that gets updated every time that patient is seen or something changes in their plan of care. And then our staff has been instructed just to scan that QR code with their phone. And because we also have access to like the medical version of that. So our physicians, if they need to be involved in the call with that patient, they can do that too. So yes, and that, obviously kids is, for sure important, but if you have patients like LVAD patients or patients with special, needs that are, that have something different than like a normal plan of care, please let us know that, and we can keep track of that for you. Just let us know when you pull us up and start working with that patient to let us know that, or have your director or you let me know about those patients. Good question, Corolla. Thank you.
John, I have a question. I'm trying to remember when we first started this. Did we give you a crew roster? And do we need to update those? And what other information should we be updating to you on a regular basis?
Yeah, perfect. Yes, when you originally signed up, our implementation team sent over probably like a 6-sheet Excel document. So we have a list for sure of all your crew roster, because we put that into our system so that when we identify, like if Sheila's on a call with us, we put Sheila as the primary patient care provider, and then documentation gets sent to the station, and then she gets that text to her phone to fill out that post-encounter survey for us. So yes, please, if you have, I might share that on the South Dakota leadership call as well. If you add or take away new members, please let us know that so we can get them put in the system. And then usually we try about once a year, and I'll bug Scott and Perry about that. We try once a year to have all that information updated on the in our software. But for sure, if you think about it, if you have new patients that are added or subtract, or move on to different things, or no longer serving with you, definitely let us know that. I'd appreciate that. Yeah, and then if you get like new medications or new equipment to use with patients, we keep record of that for you also. So yeah, definitely update us with any of that type of information. Okay, thank you for your time. You should know how to get a hold of Sheila. So if you don't have my number, she has my number. Give me a call, my email, whatever you need to do. I recognize most of the names on this call, so I've had interactions with you before, but thank you again, Michaela and Sheila, for letting me present tonight.
Thank you. I think Michaela, do you have the links? I forgot about the links.
Nope. We will be sending out the certificate and the links via email next week. So thank you
Perfect.
so much, everyone. Have a great evening.
Thank you.